to Mind Deconstructed, Mental Health and Wellness with Dr. Kaz and George.
The statements of Dr. Kaz and George are not a substitute for medical care, and our opinions are our own. If you are experiencing a mental health emergency, please seek assistance from a professional in your area.
You can contact us via Twitter at MindDeconstruct. I'm your host, George. With me is Dr. Kaz. Dr. Kaz Nelson is an American Board of Psychiatry and Neurology certified psychiatrist, licensed to practice medicine in the state of Minnesota, and an assistant professor in the Department of Psychiatry at the University of Minnesota Medical School. On today's episode, Understanding Self-Injury. May looks like a pretty busy month, Dr. Kaz. May is National Mental Health Awareness Month. May is also Borderline Personality Awareness Month, as designated by the U.S. Congress. Back in 2008, I believe.
That's right. There's been a lot of advocacy over the years, particularly for the BPD diagnosis, and Congress took this up as a national issue.
And BPD is very close to your heart, as anyone who follows the podcast would know.
Yeah, it's a diagnosis that many people have that causes great pain and great suffering. And if there's anything I can do to help alleviate that and prevent harm or injury or even death, then I want to do that.
Some other big news for Dr. Kaz. Dr. Kaz, you were named the National Alliance on Mental Illness Exemplary Psychiatrist Award.
Yep, this award for the state of Minnesota, and I could not be more honored since this is an award that's really presented by the people who matter most, which is the community of people who receive psychiatric care. So I'm very appreciative and honored and surprised and all of the above.
Is there a trophy?
I don't think there's a trophy there.
Plaque?
Maybe a certificate or something like that. We'll see.
Okay.
But I'm very honored, to say the least.
Of course. So the episode today, Understanding Self-Injury. And last episode we did self-medication, and today is self-injury. How are those two related?
That's a great question, and there is a relationship. So as we talked about last time with self-medication, the same goes for self-injury. There is usually a function or a purpose to the self-medication or the self-injury behavior that in some way meets the need of the person engaging in that behavior. We could say that there's consequences with both of those patterns, but for the person who's suffering and engaging in either self-injury or self-medication, there's some kind of benefit that helps in the short term, which is what reinforces the behavior.
Tell us a little bit more about self-injury. Like, what are we specifically talking about?
Well, self-injury takes many forms. There's a whole spectrum of these types of behaviors. So it could range anywhere from an impulsive self-harm behavior, like getting upset and punching a wall. That risks hand injury, certainly injury to property, but there's potential harm to the person themselves in doing that. There's also intentional self-harm, which is when somebody might cut their skin or burn their skin in an intentional way, usually with the goal of modulating an intense feeling. And then there's more of the habit-based self-injury, which is intentionally pulling out hair or picking skin or fingernails in kind of a habit-based way that's sometimes even out of people's awareness.
Would a person be doing all three of these, or how are these related to each other?
People do exhibit all these different types of self-harm. Usually it's maybe just one or two of these forms. There's sometimes different gender patterns. So sometimes men might be the more likely type to punch a wall or hit themselves, something like that. But those gender differences are balancing out over time.
I really don't want to minimize the behavior, but it's the punching the wall sort of seems like kind of that angsty teenager sort of thing where they punch holes in their wall.
Yeah, plenty of adults do it too, kick the car out of frustration or kick the pole. Those forms of aggression that ultimately poses a risk to one's bones or body is seen both in youth, but also adults as well.
What's the difference then for the person, depending on what sort of self-harm that they're engaging in?
Well, with this spectrum of behaviors, they all might have something common underlying them, which is it might help them to reduce intense or difficult feeling or emotion. But it works a little bit differently. So that kind of impulsive aggression, like we talked about punching the wall, that might have more to do with impulsivity in an impulsive act. The habit-based self-harm, like hair pulling or skin or nail picking, kind of gets back to an evolutionary basis where our early ancestors would do some picking and hair pulling, to make sure that there weren't mites in their fur coat, and so there is this sort of ingrained habit-based behavior where somebody might scan for bumps or imperfections or feel this internal sense of tension that's relieved through either picking or pulling hair. And then this intentional self-harm, such as people who might cut their skin with a razor blade or burn their skin or use an eraser to rub and burn or injure their skin, that seems to be a different function altogether. And there's a lot of theories as to why people engage in this. And what I've heard the most is that for people who have really intolerable inner pain and inner experiences, that there's something validating or soothing about seeing that pain manifest on the surface of their skin, and it serves a function of reducing the intensity of an intolerable emotion.
I'm assuming that's not best practice.
Well, that's what we try to understand when we meet with somebody who has any of these behaviors. What is the benefit of the behavior, but then what's also the risk, and are there different consequences? And ultimately, part of addressing these behaviors, if we can agree that they're overall unhelpful, is how do we help the person get that need met, which might be completely legitimate, but through a manner that doesn't result in injury to the bones, skin, or even bloody fingernails, or skin around the fingernails.
So NPR had an article out April 21st that talked about cyber self-harm as a new phenomenon, growing problem, where teens are going online and cyberbullying themselves through ghost or other anonymous accounts, posting mean things about themselves for the public to see, and they call that self-harm.
Yeah, that's kind of an interesting and emerging phenomena. It's something that I hadn't really considered or heard of from patients until this article came out, but it's very interesting, and there is some data and some sort of statistical methods that they use to understand the role of this behavior and how common it is. But when I read it, it actually made sense to me that people might foray into this territory because social media, particularly for teens, has become integrated into daily life. And if there's somehow a function to this type of self-deprecating or kind of a wound to somebody's image or identity, and if that temporarily meets an emotional need, I can understand why somebody would engage in that. Not that it's necessarily overall healthy, and we would maybe want to achieve that same goal through a healthier manner.
So yeah, that does beg the question, what can be done when you identify a person or patient that's engaging in self-harm?
What we try to do is very carefully understand the pattern of these symptoms. Does it just come up now and then? Are there certain things that prompt it? Do these behaviors only come up when there's certain vulnerabilities, like people are low on sleep or in stressful situations? Do people have major mental illnesses happening at the same time, like anxiety and depression that could be underlying or feeding the behavior? I think there's a little bit of a reputation that people who cut themselves on purpose or burn themselves on purpose might have borderline personality disorder, and that is true in some instances. That's one of the criteria of that disorder, but it's not true in all instances, and so there's a lot of nuance there, and we want to really understand very carefully the pattern of the symptoms. First step.
So you can't say that someone who engages in self-harm has borderline personality disorder.
They might, but they don't necessarily.
So then after you evaluate, are there instances where they're not going to have a major underlying psychiatric disorder going on?
Yeah. Sometimes people just have the self-injurious behavior and they don't have another major diagnosis along with it. If they do, what we'll often do is start with treatment of that major psychiatric illness to see if that associated behavior is at all improved in treatment. But if it doesn't improve, or the self-injury is the primary issue going on, we'll go ahead and target it directly.
And by targeted directly, are we talking medication?
Well, it depends on whether we're talking about kind of that habit-based or impulsive or kind of the intentional self-injury. There's different medication strategies that would potentially help different behavior patterns. I think there's been a lot of interest in using N-acetylcysteine, which is actually an over-the-counter nutritional supplement and amino acid. There's been some early studies with that in some of that skin picking and nail biting behavior, some early evidence for that.
Do you remember when I was in the Marine Corps and I was doing part of a study?
Yeah, they were assessing injury to hearing, as I recall.
Yep. So they did a study where did the N-acetylcysteine help prevent hearing loss because we were doing the rifle range during that particular phase.
Yeah, it's a very powerful antioxidant, and so it has a range of functions in the body and has been tested for a variety of issues, including, as you mentioned, hearing loss. But there's also some early evidence that it may help with some of the compulsive habit-based picking.
When you get into the stronger stuff, I mean, that sounds like it's just a supplement.
There's not really a medication for self-injury per se, as you know, with a FDA-approved indication. But if somebody has more of the impulsive, aggressive self-injury, then there may be a role, for example, for using a mood stabilizer to try to address that. But of course, that's a very careful risk-benefit decision because a lot of mood stabilizers have serious side effects. And so people have to think very carefully about the risk-benefit.
Those impulsive self-harm persons, and you mentioned that that's kind of related to aggression. Would those individuals be the type of individuals that are more likely to like pick a fight in a bar with someone, you know, much bigger than themselves?
Sure.
Or things like that? Okay.
Yeah, somebody who kind of goes into that fight or flight threat mode. Maybe they have an emotional sensitivity, or maybe they have prior trauma that makes them primed to engage in fight or flight kind of activities. And so it can be sometimes explained by those sorts of developmental issues. Although there's no, again, FDA-approved medication for that kind of intentional self-injury like cutting or burning, often will employ a very comprehensive strategy to try to address that. That may or may not include medications, but definitely a comprehensive evaluation of the symptoms, other associated symptoms, setting a hierarchy of different symptoms to target, and likely include a combination of medication and therapy as a sort of a comprehensive approach.
As a layperson, I would think that some of the different forms of therapy that we've talked about previously would maybe benefit self-harm behavior.
Yeah, that many types of therapy have been tried and successful in some people with all these types of self-injury. If somebody's really motivated to address that behavior, then psychotherapy can play a role.
And what about the more mild behavior? I mean, because with self-medication, we talked about how, you know, everyone self-medicates to some extent. I'm not sure that everyone necessarily engages in self-harm to some extent, but are there those like, oh, I, you know, always, you know, scratch my, I don't know,
scabs or something
you
like
know,
that.
I
Yeah.
always pick my scabs off
Yes.
because the pain feels good or something. I don't know, but
there's as with anything, a whole range of different types of behavior in these categories. And we've talked before about if it's really crossing the line of dysfunction, that's when you might want to get help. I'll just tell a story. I historically have been a terrible skin picker, like pulling hangnails around my fingernails and biting my fingernails. I know it sounds gross, but it's something I'm very familiar with because I'm kind of a professional in that area. And up at Morris one time, I turned in a paper to my science professor and had blood on it because I'd been picking my fingernails so bad. And that was really embarrassing and shameful moment. And of course she noticed and said, hey, that's gross. Next time you might not want to turn in a paper with blood on it. Right? So very compassionate professor I had. If you're listening, hello, I'm doing much better with that. But it's been years of working on kind of managing that behavior and keep it under wraps because there's such an ingrained tendency for me to kind of scan for scabs or bumps or wrinkles or things that your fingernails can catch and pick. And it's, you know, a challenge. It's sort of irresistible at sometimes. I can kind of relate to that.
Sorry, I didn't mean to pick your old wounds there.
Good one, George.
Well, that was probably one of the best jokes I've ever gotten on this show. So
Nice.
I think that we should wrap it up.
All right. Until next time. Goodbye.
Thank you for joining us today. This podcast was produced by Kaz and George. Music by Paul.
He's the best.
Contact us and send us your questions on Twitter at MindDeconstruct.